We move on to our panel discussion, complication and its management. The moderator for this discussion, it will be for 30 minutes. It is Dr. Deepak Sarin. He is a Director, Head and Neck Oncology, Cancer Institute, Medanta, Gurugram. And the panelist for this session is Dr. Jay Dhadania, Medical Oncologist at Sterling Specialty Clinics, Dr. Mandar Deshpande, Consultant Head and Neck Cancer Surgeon at Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Nilesh Mahale, Radiation Oncologist at Bharat Cancer Hospital and Research Institute, Surat, Dr. Prakash Uditra, Radiologist in Ahmedabad, HCG Cancer Center, Dr. Priyanka Patel, Medical Oncologist associated with HCG Cancer Center, Dr. Purvi Patel, Senior Consultant Head and Neck Cancer Surgery at HCG Cancer Center, Ahmedabad, Dr. Saurabh Sandaria, Consultant Radiation Oncologist at Sterling Cancer Hospitals, and Dr. Shamit Chopra, Attending in Chair, Department of Head and Neck Surgery, Patel Hospital, Jalandhar.
She's at Surat, and there is a huge majority of Surat oncologists in the panel.
Hi, good afternoon. So, in the last 6 years, this is the 4th panel on complications I'm doing. I think there is a message in there. When you think of complications, somehow you think of me. Second time in home. I'm holding this against you. So anyway, we are cut down to 30 minutes.
You handle best others' complications, so that's why you are here.
So we're cut down to 30 minutes, which does mean I may not be able to have cases that may involve everybody. But if there is something you can add, just please take the mic and speak, even if I don't direct a question at you. So the first case, this was a 59-year-old male, ex-smoker, no other medical issues. He had a T3N0 left transclerotic squamous cell carcinoma, which was treated by chemoradiation. Unfortunately, 10 months later, he developed a local recurrence. The PET scan showed just local disease, nothing in the neck and no distant metastases, and he came to us with this history. He underwent a total laryngectomy with a primary closure and a left selective neck. On day 7, he developed low-grade temperature, a single spike, and on day 8, we noticed increased drain output. Clinically though, his neck and stoma looked unremarkable. Systemically, he was stable. He was still on RT feeds. He had drains in place. So the question is for the surgeons. What do you assess is going on in this patient, and how do you take it forward? Mandar, please.
Yeah. So one thing is that obviously if the drain has increased, the first thing and that we are always thinking about is it a leak which is there, and it's a post radiation laryngectomy. Have you put in a flap or not put in a flap? That's something you not put in a flap. So one thing is that obviously looking at the color of a drainage which is there, that will give me some kind of an indication, is this a leak? Second thing, always when there is a leak, I'm also looking at, is it, because that leak can also give to a bleed, which is a second thing which I'm always worried about, because the leak, if it goes on to the vessels, that can lead to a blowout, that can lead to this thing. So if I'm suspecting a leak, my second thing would be perhaps to lateralize that leak, kind of this thing, and it does not go on to the vessel, so let it come out completely. That's something which is there. If it's a very small quantity leak, this is not like a early leak which has come out on a first, second, third day, which is unlikely to heal. But yes, it's a post radiotherapy. If the quantity is very high, then I would be kind of more keen to go in and kind of drain it out,
So
put
we'll
in a
stick
flap.
with this patient, like a
Yes.
late leak that looks
Late
like a
leak, I would perhaps not initially try to treat it conservatively rather than being very, very aggressive. Treat him with antibiotic, lateralize it, and wait and watch for some period of time. See that obviously my markers would be that if there is any sign of a kind of a bleeding or something, then obviously I'll go in. Otherwise, initial treatment would be a conservative treatment, lateralize it, giving a compression dressing, and wait and watch.
So,
Antibiotics.
so you're saying the diagnosis is essentially clinical. So does anybody do a scheduled swallow study in a laryngectomy to look for a not an overt leak, or do we all diagnose pharyngocutaneous fistulas based on clinical presentation like this?
I said like we are not doing any swallow test, but yes, if the drain is dirty, then itself suggests there is some leak. I would also add to this, like we should give a good nutritional support to this patient when they are in, not to remove drains, but when we see the
So
drain output is
Purvi,
high.
I'll come to management later. I
Yeah,
think my
okay.
slide is misleading. Actually, I wanted an assessment of what do we think is going on and how do we diagnose a leak. We'll come to management in a bit. Sham, you want to add?
So, completely agree that we first need to establish what's going on. A late increase in drain output with normal clinical parameters, otherwise I'm assuming the patient is systemically stable also. Either it's a localized infection or it is a late onset chyle leak, probably precipitated by some increase in intrathoracic translating to intracervical, and of course it could be a pharyngocutaneous fistula. In our practice, typically the way we would approach it is a combination of what Dr. Mandar said, maybe with a couple of different perspectives. If the drain is out, to answer your question from
So
our
the
end,
drain is in.
the
This
drain
patient
is,
has high drainage in the suction.
so yeah, so the drain character is going to give us a clue. Usually in a post-radiation patient you have more mucoid salivary secretions. In a per pramum patient you probably have more frothy stuff. Chyle of course is pretty much a synchronous, you get some idea, but we tend to send that for triglycerides or chylomicrons. If it's suspected saliva, we'll send for amylase. These are easy tests of the drain output, which can give us some idea. If it looks like infection or purulence, then in that case we'd send a culture. So some kind of biochemistry and microbiology would help us as well.
Okay. I think it does. Yeah, of course. Yeah. So my question, what I wanted, if somebody could throw an appointment, is there a role for a scheduled swallow study prior to initiating oral
that's right,
feeds?
Srab. In fact, this is just the situation. When you have a delayed leak, the highest possibility is you're looking at a leak, at an anastomodal leak. And therefore, we do a gastrograph and swallow to establish whether we are dealing with a leak. Typically, we don't do it on until 10 days. But if you have a situation like this, by all means, I would do a careful gastrograph and swallow.
Deepak, you have a paper on the role for low volume gastrographin routinely after laryngectomy to pick up non-clinically overt leaks. Can you just shed some light on that?
Yeah, this is the practice in our unit, especially if the patient is salvage. If you looked at that paper, there was a significant number of salvage cases versus per primer. So the problem with salvage cases, at least in our experience, is that many of them break down at 3 weeks rather than the first or second weeks. It's the second phase of healing which is a problem. So we routinely do on day 10 or day 14 a small volume gastrographin, which is 3 to 5 ml, and then we do a signed video fluoroscopy. And in that paper there were leaks, but they were not clinical leaks, they were only radiological leaks. So if you pick up the radiological leaks and further delay the intake, you prevent the clinical leaks also. So part of our protocol is to do routine, especially in salvages, do a routine small volume gastrographin at day 10 or day 14 prior to starting the feeds.
Okay, I'll just put this paper out, then I'll take your comment. So, so this is also a paper looking at whether a routine swallow study can help. And I mean, what they showed that is that many patients have blind fistulas, which are still not overt pharyngocutaneous fistulas. And a swallow study can pick them up. And if you change your management with delaying oral feeds, pressure dressings, then potentially you can reduce a overt pharyngocutaneous fistula from forming. I think in your paper also, blind leaks almost 40-45%, but if you manage them, then overt fistula only under 10% in those patients. Please.
Yeah, my comment is that in this case, when there is
No, not in this
established-
case. I
yeah.
think this is obvious.
So this
already
is an obvious feature. You
this
don't need any study.
You don't need any study.
Yeah.
Agreed.
This is a very good paper, and I would say that at day 7 in a chemo-radiated patients or radiated patient, you have done a salvage. This can be a good thing to do as a gastrographin study, small gastrography, and find out potential patients who will leak.
Yes,
Okay.
similarly, we have the exact policy, 10th day, any salvage laryngectomy, do a gastrographin, but in this, as I said,
This is already overtly a leak. Okay. So now, this is where the only time our medical oncologists come in, because when we add chemo to radiation, we get higher fistulas. So this is all that I had on the panel, or we might have time for, unfortunate. So we know that the best therapy for any complication probably is to prevent it, and there are tons of risk factors that are associated with development of a pharyngocutaneous fistula, and one of them that we face a lot today in our era is the increased risk seen in patients who are chemoradiated. So I'll just move this on to preventive measures. Maybe there are a couple of preventive measures we can discuss. Mandar, you did ask me whether we did an onlay flap or not. And there is enough evidence, and Harsh also talked, and it's been talked about many times in this conference, that an onlay flap to buttress your closure causes significant reduction in leaks. And there is, this is what one would do, is take the pectoralis muscle, bring it into the neck, and just use it to buttress this. And there is also ancillary evidence from a couple of other papers saying that it sometimes may not reduce the leaks, but it may reduce the time taken to heal, or it may reduce the number of secondary procedures you may require to heal a fistula if it happens. So the question for the surgeons is, in all chemoradiated patients who are undergoing salvage total laryngectomy, no pharyngectomy, just a total laryngectomy, do you do a onlay flap, or are you still selective on where you will use it?
yes, I do it in all.
In all
patients.
all patients.
All patients who have undergone
So I
chemoradiation.
guess we didn't do well.
So, with your permission, can I backtrack for 10 seconds? I think the question that was made and the comments that we had was extremely important. Of course, we understand the importance of doing a solo study, whether it's going to be in that patient or in similar patients, whether it's going to be symptom directed or finding directed, or whether it's going to be part of protocol is the question. We follow symptom directed, and maybe I'd request you to find out probably if more people would do symptom and clinical finding directed solo study vis-a-vis doing it as part of routine protocol. We don't do routine protocol.
Got it. It's fine.
The only situation where I would not put in a onlay flap is something like a T1 glottis, which has been radiated previously, so it's like a limited field radiation, and
So
now has
non-chemoradiated, you're saying? Like radiated? only.
radiated kind of a this
Fair
thing, and has recurred, and now it's like a T4 larynx, and that's the reason why you have to do a laryngectomy. So then I would not put it.
Fair enough.
But otherwise, every
Fair enough. We don't routinely do it, we're selective, but it seems like majority of surgeons would think one should routinely do
But
it
sir,
in all
I will
salvage
also add to
cases.
this, if in selected cases, if primary closure is done, then it should be a double layered, what Dr. Shamit showed us in the morning. So at least it should be buttressed with some muscle layer.
The constrictors, you mean?
Yeah.
Okay. So the second thing, and so I'll just move to, let's say if we are doing a salvage laryngopharyngectomy with now an inlay flap, which means you need a patch. Sometimes this is a different scenario. It's where primary closure is not attainable, and you're going to have to use a patch to reconstruct the pharynx, and you need a flap. Choice between free flap or a pectoralis major, again from the surgeons. Your preference?
It's largely driven by three factors in my opinion. One is the residual pharyngeal strip that you have left after you've done the laryngopharyngectomy. Second is also the habitus of the patient, depending upon what free flap we are going to choose, and of course we've just had a great debate on that.
So non-circumferential defect.
Non-circumferential.
It's a patch.
Yeah, so a less than 3 centimeter, typically, and that's our institutional protocol. We've looked at our own experience with about 150 odd laryngopharyngectomies. Less than 3 centimeter residual viable pharyngeal mucosal strip at any point during the circumference in a salvage patient, we'll typically do a free flap because we think it's difficult to tunnel the pec. Now, there are some exceptions, and it's subjective also. with regard to the habitus of the patient, which is what I was getting to. A very thin patient, you might get equally good results. And the advantage of using a PEC sometimes in those instances is that you can very nicely buttress it with the constrictors, so you actually get a full 2-layer closure, which sometimes some free flaps are also not able to give you.
Sir, I would definitely go for the neck vessel status also before choosing a free flap. So sometimes all the chemoradiated patients, if plastered neck is there, and there might be a very difficult situation like intraoperative also, if we are thinking of doing a free flap, we might have to switch to the pectoralis major flap.
Agreed.
If the neck vessels are not good and they are like.
I would say in this particular, now today's day and age in head and neck, almost reconstruction, almost we have shifted to the free flaps rather than pec major flap. But this is one situation where we prefer a pec major over free flap. One reason being the muscle will act like a cover for the vessels to prevent a kind of a, if there is any kind of a vascular a blowout or something which is there, which if there is a post chemo radiation, there is always a high chance of a leak which is there, which will not go on to the vessels kind of a this thing. So we prefer PMMC over free flap in this particular situation. I would say in almost all patients we would do a PMMC rather than doing a free flap.
So,
Mandar, you make a very important point, and I totally agree. In a thin patient, we would definitely do that. But I think I want to also respond to what Purvi said. I think one set of vessels that almost always escapes unhurt after radiation is the transverse cervical pedicle. So please look for it. We often resort to using the transverse cervical pedicle. And the second thing is, if you feel, like you said, the pec is difficult to tunnel or anything, then using a faciocutaneous flap is actually better, speech-wise far better than using the pec. The pec takes long for the muscle to atrophy. With a faciocutaneous, the speech rehab is much quicker, and you can use the transverse cervical vessels.
so I'll put up again a viewpoint that we get from literature, and that goes a little bit aligned with what Dr. Haribhakti is saying. That two meta-analyses I've looked at which have used free flap versus a PEC for a patch pharyngoplasty. With the free flap, fistula rates are significantly lesser. The need for second surgery is lesser, and more patients acquire speech, a point that you were making. And in the second meta-analysis, again, it shows lesser fistula rates and actually lesser stenosis rates. But I do agree with all surgeons that in practice, and even us, our preference is to go for a pec flap. And I think maybe there are other factors we have to consider. It's all centers are familiar with raising it. We feel very comfortable. You can double team it, so it doesn't always mean it will be a long operation. And I think the fact that you get muscle to cover the vessels is really important, because that's a real big worry when you have a fistula. Also, in our experience, I think when you put a pec for a fistula, if they break, which they sometimes do, they often break contralateral to the primary side. Like they break on the side opposite to the pec. So if you've not done a contralateral neck, you generally don't have saliva bathing your neck vessel. So I do agree, literature really does favor though that free flaps seem to be much better with healing. But practically we often land up doing a pectoralis in this situation. And any thoughts or opinions or disagreements? This one?
Yeah, so we understand these are not randomized trials. These are the data, as I understand.
This is meta-analysis of published
so,
literature.
So what happens is that when you select patients for PM, there are so many patients who had bad vessels in their neck.
Understood.
So things were
Bad necks, bad patients,
yeah.
bad
So these are the
habitus.
shortcomings of meta-analysis. If we see this, the fistula rate, we have to understand that also, that in 25% patients, most of them healed without anything. These fistulas heal without anything. And the most important thing probably is what Vijay says, the speech, TEP. It functions well, but if you see long-term results, they don't have produced any long-term,
Yeah.
but in long run, they are almost equal.
Quick comment.
Yeah, in addition to all of these, you have the issue of putting in a monitoring paddle for a free flap.
Agreed. Okay. So on prevention, there's another topic I wanted to bring up again. That this is something we have no experience with, but um, literature talks about it. Salivary bypass tubes. Any of the surgeons use it routinely, selectively? Your thoughts on it?
No experience.
No experience.
So I trained at centers which used to use it, but again it was surgeon driven, and at that time there was no data. We presented our first 6 years of this experience at the academy meeting in San Diego in 2016. We, again, retrospectively based on our experience, because these are patients who need to be optimized retrospectively, prospectively, we looked at 3 criteria where we use salivary bypass tubes upfront to prevent or preempt the presence of a fistula. One was prior history of radiation therapy with circumferential defects. Number 2 was, we just talked about subjectivity, Dr. Deepak. So subjective idea about the closure being tenuous was one. And the third was a really poor local systemic state, which was the third point that I was initially mentioning. Local anatomy and radiation arthritis, hypoxia we've talked about, but systemic state is also very important. Hypoalbuminemia, prior history of radiation, hypothyroidism.
So high risk cases, where you think the risk of fistula is high.
So we've done that, and we realized that in that subset of patients, we had a lesser incidence of fistula. Again, it was a retrospective, not driven to be able to achieve any outcomes except analysis of our own experience, but we've been using it in those subsets.
Please.
It's a wonderful paper which is put up there. Our experience is that patients are really very uncomfortable using this salivary bypass tube. First thing. Second thing is you really need to get a very snug fit. If you're not going to get a very snug fit, the main concept of saliva not coming in contact with suture line is lost. So you really need to be very particular about what size of tube you're choosing. And this does say that in high-risk patients, the putting of the SBT may help with this one.
Put up the data if you want.
Yeah.
Can I have you continue in a minute? I'll just read out the paper, then you can add to that.
Yeah.
So in this paper, which was again a meta-analysis of all published, there seemed to be a trend favoring salivary bypass tube, but it didn't reach statistical significance. But this is for all surgeries, all comers, salvage, per primum, laryngectomy, pharyngectomies, all mixed bag. They did do some subgroup analysis when they only looked at papers where the salivary bypass tube was frequently used, and they took out publications where it was very infrequently used. They did find it made a difference. And when they did laryngopharyngectomy with pharyngeal reconstructions, they did find it did help a little bit. But again, I see it's not universally used. So if you want to continue under this background.
I think what in this study, there have been a couple of studies where there's a large number of patients in that group. Couple of studies, I think they contribute a big number. Some of the studies are like 600 patients or so. So I think there could be a bit of bias because of some studies
great
contributing.
Heterogeneity. They said
great
massive heterogeneity.
Massive heterogeneity.
In this meta-analysis.
But I think if you really use it very good, nicely, for a limited period of time, it could be useful, because there are a lot of comments which says that if you keep it for a longer time, it could increase the risk of infection along the suture line.
So to answer part of the question that was brought about, we maintain a limited inventory of 1 salivary bypass tube per size each. For those of you who are uninitiated, there is a flange which is different. So there is a hood, and without any relevant financial associations, there is a HRL, and there are other tubes as well, one with a larger flange, but the diameter remains constant. So I agree with your point that it's difficult to decide diameter when you have variable diameters across the length of the reconstructed neopharynx. That being said, it largely ends up being subjective. We have in the past switched patients from smaller to larger, especially when they became, like Deepak is mentioning, a clinically overt fistula. In that sense, we've used it in the post-emptive setting also, and there our experience was fairly good.
And I think one of the other concerns that I have whenever using SBT is the lower end of the SBT. Lower of the end of the SBT is quite pointed, and you're really not sure how it's going to be sitting there, whether it's going to cause an iatrogenic injury to the lower segment of the tip where it is standing.
So because of availability of tubes in our country, we've largely moved towards using the hood tubes. The hood tube has a very nice rounded silicone tip. It's actually not it's not traumatic at all. That being said, I think all points are well taken about something which does not have much evidence in literature.
Anybody else has any thoughts on salivary bypass tubes? So this is a nice paper that I came across, and I thought it's nice to put up, because we look at preventive measures and sometimes we are not sure how much technique makes a difference, but it's a nice paper. It's a project, it's Fistula Zero project paper, where 3 principles were followed meticulously: horizontal closure with a barbed suture, a salivary bypass tube in all, and an onlay flap if it was pre-treated. Using these three principles, laryngectomies were closed. 77 patients, a third were pre-treated, which means 2/3 were per primum, but a pharyngocutaneous fistula rate of 1 patient. That's really remarkable. So I think there is something to giving thought to prevention. I think there is something about technique, and there is always an aim that we can strive for of reducing our complications by just incorporating some other practices. It's just I found the remarkably low fistula rate, so I thought I would put it up. Now I'll come to management. I said we'll come to management of fistula in general, and maybe this, and again in literature there is just very little things that have consensus. So maybe we will get the thoughts and get your thoughts on this from the panelists. So, okay, so if you think there's like in this patient, so this patient has overt fistula because the drainage is high, it's 100 ml per day, it's clearly a fistula, it's not chyle. How would you manage? Would you open the wound, pack him, put pressure dressings, or how would you manage this patient going forward? I'm assuming NPO and RT are going to be there. Surgeons, how do you manage patients like this? Like a patient like this particular patient. Well preserved, no systemic toxemia.
If it is not a big fistula, we will try to go for a conservative management for at least 2 to 3 weeks. If there is a slough or something, we can just remove the slough.
So this is a closed
if
wound
pus
yet,
is coming,
it's just increased drainage in the drain. That's all we have right now. Abhi tak itna hi hai. So, what do you, like, okay, my question, let me ask specifically. When we were training, we used to have to, if you thought fistula, you opened the wound and you packed them and you pressure dressed them. This is what we used to do when we were training.
No, we don't open the wound.
You don't open?
No. If it is already lateralized, like it is draining through in the drain, so better not to open.
You don't open?
But yes, if there is a pus infection is there, then we can do pus culture sensitivity.
What is the
and we
amount
can
of
give antibiotics accordingly. Not to remove nasogastric tube.
What is the amount of drainage you are getting in 24 hours? Is
Let's say
it
about
decreasing?
70, 80 ml?
I think you can wait and watch.
Yeah, we can
Conservative
watch
treatment.
conservative management.
Time be little.
Then high nutrition also, high protein diet to the patient. If anemia is there, it should be corrected. And yes, good antibiotic.
Anything different? Anybody would open the wound?
So this would
Or
be,
what are the indications to open a wound like this?
so this would be the case that we were trying to make about clinical findings directed or symptom directed management. We do a swallow study, and again, there's no criteria to my understanding in literature about this. But if you have a large leak, like Dr. Mandar said, is bathing the vessels and everything, in that case, we'd be obligated to go in. In case it's a very small
No, but how do you
incipient,
know that in a closed neck?
well, you're doing a swallow study, right? You're doing a swallow study with video fluoroscopy.
I see.
So if it's a small, very small kind of trail track appearance or something like that, and it's not really going up to the area of the vessels, which you can easily isolate, because you can do contrast and then follow it up with a CT also, not just video fluoroscopy. In that case, I agree with the two opinions expressed that you manage conservatively. Part of our protocol is also to put in a salivary bypass tube in incipient leaks, but not in large leaks.
My this thing, as I said, is that as long as patient is not showing signs of any infection, no frank pus, no signs of sepsis.
But I think local infection is
No, that's what.
invariable,
As long as the skin flaps are well stuck, no signs of any kind of a warning bleed, no slough over there, and we've done a some swallow study which has not shown any major kind of a leak which is there, small leak. I would treat it conservatively by just tube feeding, compression dressing. I'll sit tight. Wait for, obviously, for a duration for which you need to wait, and as long as it is not showing a increasing trend or it is just not going down, or how long you need to wait, I don't think there is any guideline for it. But I would just wait, see how much this thing, I'll nutritionally build the patient, and any of these things, obviously the most warning thing would be any sign of bleeding. If that will be the first thing, if there is any, then I'll go in.
To Deo?
If you have a closed wound and you have suction drain in place, the moment there is a fistula, the suction will not hold. And you will know that something is wrong. Then you give a feed, and you will know that there is a leak, methylene blue, whatever it may be.
Methylene blue test or anything.
And then afterwards, the surgical principles are same. Fistula is a fistula, connection between two epithelial surfaces. convert a septic fissura into a clean fissura, create a convoluted tract into a straight tract, and if you have not any other factors, and there is no obstruction distally, tissues are healthy, it has to heal.
I think, yeah, thank you. I think that is great wisdom. No, that's great. No, perfect. I think you already, no, yeah, that's true. So I'll tell you, I mean, I just need to, compulsively need to share what we do. I think I have a much lower threshold for early correction because I think the biggest problem with fistula is chronicity, and I think we have to prevent that. So the first thing, as Ravi said, it's no point keeping a suction drain. If you have a fistula, it's better to know from the low volume swallow where the leak is and to lateralize it by putting in a small non-suction drain and letting it drain out directly away from the stoma. Very, very important that the drain should come out away from the stoma. And then you wait for if you find a high output, if you find that things are getting messy, go down quickly. I think it is better, much better through all these years. I used to follow what was said earlier that just wait, put a compression dressing. No, I've stopped doing that. It's better to confront the truth and to act quickly. So if you find a large leak, it's better not to keep on waiting.
But as you are telling, Dr. Sarin, if you have a well-stuck neck,
Yeah.
I always tell people to use two trocar, two drains, and two separate bottles. So what happens, you will know which bottle is draining the saliva and which bottle is not draining the saliva. Probably if the bottle is not draining saliva and it is keeping the flap stuck, I'll continue to have that. And the bottle which is draining saliva, we know what is the point. I'll open up little bit of it. That's it. So it is important, as Vijay has told, wait and watch policy is wrong. If you have a complication, the most important thing is anticipate, detect, and accept as early as possible. Rest is very simple.
So I think we're out of time. I'll just conclude by saying what we did and what we do, which may be a little contrarian to what you said. So I think in a late fistula, if the skin flaps up, so we always like to use an incision that's separate from the stoma. So one of the advantage I think is if you get a late fistula like this on day 8, day 10 or day 14, even if it exteriorizes through the incision line and doesn't exteriorize through the stoma. So you don't get stomal breakdown, you don't get stomal stenosis, you don't get stomal retraction. So so this patient did have an incision like this. And the other thing we always do is we place a drain between the incision and the stoma. Again, this is to help in case you get a fistula to lateralize. This is what we do. We of course place the two drains in the neck and the usual drains on the side. This is an extra drain that we place. So in this patient, we just let the wound stay closed. Since he had no systemic toxemia, we actually don't stop water. We allow them to have water. We don't feed them by mouth, but we allow them to have water on the principle that it acts as an irrigant and just cleans the wound out, because if you're already bathed in saliva, that's not a clean wound anymore, and they're almost invariably infected. So they drink water, and that does an internal flushing of the wounds akin to an open dressing. And we just leave these patients with this drain, and they can go home once the pus is cleared and the drain is just clean saliva. They can go home, and when the drainage stops, we pull it out, feed them orally, and there. So this is what happened in this patient. So we did exactly this. We kept the NG. We allowed water by mouth. The negative suction drains kept, and sometimes if the flaps have stuck down and the drain is far from the fistula site, it doesn't always leak. I think if it leaks, you've got a big fistula, and that wound is going to break. It's unlikely you will end up with a closed wound in that situation. So he took 4 weeks. His drainage stopped. Again, when we started, again his drains opened up a little bit, but they stopped again a week later. And finally his fistula was healed, and he's 6 months post and he's done. So managed with a closed suction drainage system, which for small leaks sometimes works, at least in our experience it works well. And we don't open a wound unless there is an imperative reason to open. But that's what we follow. Yeah. I think I had 2 cases for the radiation oncologist, but I'm sorry, we're cut down to 30 minutes, so I can't bring them on. I really apologize. I couldn't get opinions from all of you. So we can do 1 case? Great. Thank you. So then I'll get straight to the point on the case. So this was a 56-year-old male. He received radiation 70 grays for a supraglottic cancer almost 10 years ago. treated outside, so I don't have many details of what was done. He came to us with increasing breathing difficulty for 2 months. Diet was fine, he was eating reasonably well. He had mild stridor, which clearly increased with walking, increased with effort. And he had a PET scan done outside, which he came with, which showed no disease. So this is 10 years post-radiation, breathing difficulty, no other issues, no evidence of disease. This is his scope exam. So a little bit of mobility on the right chord, the left chord and the left hemilarynx and the left arytenoid absolutely fixed. And of course inadequate abduction and an inadequate airway. So this patient had a tracheostomy. We evaluated the larynx under anesthesia. We had hard fibrosed cords, not easy to retract even with the instruments. Maybe the right side a little more pliability, but fairly rigid. So to the radiation oncologist, what's going on here? How frequently do you see something like, it's not a common occurrence this, but we do see cases once in a while of laryngeal stenosis or laryngeal rigidity or delayed cord fixity following radiation. How frequent is this? What's the possible cause, and can you medically manage this?
I have not seen too many follow-ups at 10 years, but it's, as you said, it's not very common, but maybe around 5 to 10% in our practice. If it is mild, then we'd obviously manage conservatively. Initially,
so what's the conservative? Like, is there a medical management for a case like he's compromised airway, tracheostomized because of this? Is there a preventive measure in radiation we can do to prevent delayed fibrosis? Is there something we can do?
Certainly, because we don't know how this patient was treated, but with the use of advanced technology, the fibrosis is a outcome of two factors, variables. Like patient factors would be if the patient has continued smoking after the initial treatment. That is one thing. Then regurg, reflux, and then what were the volumes treated? If we have treated excessive volumes, that would lead to more fibrosis. And the control of hotspots, what is the dose delivered? So if we can control the hotspots properly, then the incidence of fibrosis is much less.
Any options in medical management?
No medical management for this kind of
refer to surgeon?
So we have to decide the goals, like patient should have a good breathing.
Have you seen patients like this?
Yeah.
You see, right? Yes. Bilateral cord fixity delayed. He had documented
recently we have seen a patient who was operated for this situation post radiation. Somebody did arytenoidectomy, and then the patient had a mass. Patient was aspirating. So these are the set of patients we have to take decision very wisely, very cautiously.
Shamit, you see patients like this, or seen, and what have you done for them?
Yeah. Seen, again, I think 1 to 2% patients, as reported in literature, will develop some apparently idiopathic vocal fold palsy, as a radiation oncology colleague mentioned. You will have fibrosis of any part during the course of the recurrent, typically at the level of the cricothyroid joint, because we're talking about head and neck radiated patients who are getting palsy, so it's mostly a cervical cause, not a thoracic cause. When we get them, we we've not seen them spontaneously recover in our practice. I'm yet to remember a single patient, maybe one odd, but nothing recovered spontaneously. At that time, a functional assessment is of importance. The patient that you showed is, even though he's pooling saliva at the endolarynx, may be penetrating, but is unlikely to aspirate. I agree with Purvi, we don't mess around with the retinoid at all in a post-radiation setting, but we would have laryngology see these patients, do a FEES, and also plan very selected patients for something called a Kashima chordotomy. And the thing that I've learned after having been part of 8 to 10 of these is that you have to take the cut all the way to the inner perichondrium of the thyroid cartilage, otherwise the Kashima does not work. Sometimes a posterior chordectomy might be required, but never an retinoidectomy. Not from this subset, but we have our data from TORS, which shows us that a retinoid resection has enteral dependence pretty much long term, and when I say long term, at least 2 years. So you don't want to mess around with the retinoid, not even with the vocal process in that case.
I'm happy to see you pick the mic because I wanted your opinion on this. Would
Yes,
you do an endoscopic procedure
yes,
on this
I
patient?
saw many of these cases. Most of the cases are due to the posterior glottis stenosis. That means the fibrosis of the interarytenoid muscle. So it's mimic the bilateral palsy, but it's different things. So I completely agree that you have not to touch the arytenoid because it's disaster. You can cause chondritis, chondronecrosis. But I solve the problem sometimes doing just a posterior chordotomy. Just cut completely the muscle until the paraglottic space, making just a small triangle posteriorly and including maximum the vocal process. It may be a partial ventriculectomy just to expose the floor of the ventricle. This can help you to decannulate the patient, but don't touch the arytenoid. This is a good message.
So I had a point regarding the workup of these kind of patients who do show to us with severe post-RT fibrosis. It's important to rule out a recurrence in them, and we would definitely want to do an MRI, not just a PET-CT, because an MRI, especially with the diffusion-weighted images, would help to differentiate between pure inflammation vis-a-vis like a tumor recurrence.
I get the point.
Yeah.
Just for argument.
Yeah.
If it's a big enough cancer to cause fixity, a PET shouldn't miss it, right?
Absolutely, absolutely, sir. But sometimes these are quite submucosal, and it's not often seen on the endoscopy.
Got it.
There is a simple maneuver to perform just to make a diagnosis. You put the patient in microlaryngoscopy and you dilatate the two vocal cords and you can appreciate like a fibrosis bridge between the two arytenoids. This is posterior glottis stenosis. So it's an endoscopic diagnosis. But you can combine with MRI just to differentiate with the ankylosis of the joint, but most of the time it's just a interarytenoid fibrosis.
Deepak, a positive PET is not as...
Negative.
Negative PET is 100%.
This is negative.
But if the PET is showing positivity, it does not mean, because once I believed PET and it was radionecrosis, the whole tongue had gone and the lady had a bleed. So a negative PET is reliable. A positive PET, question mark.
Okay, great. So anyway, I think the point's well made. I had a video of what another surgeon had done. This is not mine, which was a posterior chordotomy and then adequating. But I think the point's already made of be very selective, be very careful, and I think be very conservative in how much you open. Otherwise, patient may land up with 2 tubes instead of 1. That's a disaster. We have 2 seconds. We're done, right? I think. I had another case for red onc, but I think we're done. Okay. Thank you very much. Thank you.